Welcome to this audio recording. This is a clinical approach, a hypothetical case with questions that test the key concepts for a particular disease presentation. In this episode, I will discuss the case of a 23-year-old with right lower quadrant abdominal pain. A 23-year-old woman presents to the emergency department with a 12-hour history of right lower quadrant abdominal pain. Question 1. What are the differentials for right lower quadrant abdominal pain? Some differentials for right lower quadrant abdominal pain include appendicitis, a perforated peptic ulcer, ureteric colic due to urolithiasis, diverticulitis, typhoid, amoebiasis, regional enteritis, right-sided pyelonephritis, testicular torsion, acute pancreatitis, rectal sheath hematoma, carcinoma of the cecum, hernia incarceration, and inflammatory bowel disease. Question 2. What are the differentials for right lower quadrant abdominal pain in women? Differentials for right lower quadrant abdominal pain in women include a right-sided ectopic pregnancy, ovarian torsion, pelvic inflammatory disease, tubo-ovarian abscess, and ovulatory pain. Question 3. What are the differentials for right lower quadrant abdominal pain in children? Some differentials for right lower quadrant abdominal pain in children include mesenteric lymphadenitis, pseudoappendicitis, which is caused by Yersinia enterocolitis, pneumococcal pneumonia, gastroenteritis, intussusception, Meckel's diverticulum, and Henoch-Schönlein purpura. Children with acute appendicitis may have typical symptoms of viral upper respiratory tract infection, followed by onset of true appendicitis. Continuing with the history, the pain originated in the umbilical region and radiated diffusely across the lower abdomen and is now localized in the right lower quadrant. It was of sudden onset, sharp, and constant with increasing intensity. Severity was rated 8 out of 10 on a scale of 1 to 10, with 1 being no pain and 10 being the most pain possible. She took over-the-counter Ibuprofen, 400 milligrams, but this did not alleviate the pain. The pain was exacerbated by lifting the right leg. She has vomited twice and reports that she has not eaten for 24 hours due to a lack of appetite. She opened her bowel post-onset of the pain with no change in the consistency of the stool and no blood or mucus. She does not have abdominal swelling, dysuria, increased frequency of micturition, vaginal bleeding, or purulent vaginal discharge. She is nulliparous, and her last menstrual period was 2 weeks ago with no complaints of dysmenorrhea. She also has no history of unintentional weight loss, episodes of dyspepsia, strenuous physical activity, or abdominal trauma. There is no significant past medical and surgical history. Drug history includes the oral contraceptive pill. She has no known drug allergies. There is no relevant family history, and she does not smoke, nor does she use recreational drugs. She drinks alcohol occasionally. Question 4. What is the usual first symptom of acute appendicitis? The usual first symptom of acute appendicitis is anorexia, which occurs 95% of the time. Question 5. What is the classic sequence of symptoms in acute appendicitis? The classic sequence of symptoms in acute appendicitis is anorexia, then periumbilical abdominal pain, followed by nausea and vomiting. Then the periumbilical abdominal pain shifts to the right lower quadrant and may be accompanied by fever. Murphy's triad refers to migrating pain, nausea and vomiting, and fever, usually in this order. Vomiting is due to pylorospasm and usually involves stomach contents. Question 6. Why does periumbilical pain migrate to the right lower quadrant in appendicitis? The visceral peritoneum is supplied by the autonomic visceral or splanchnic nerves. There is no laterality to the unmyelinated C fibers of the visceral nerves, which enter the spinal cord bilaterally at multiple levels. Hence, the CNS attributes the pain signals to the physical location, whose dermatome corresponds to the same entry level in the spinal cord. On the other hand, the parietal peritoneum is supplied by the somatic nerves. The appendix is part of the midgut. Visceral pain from the midgut is referred to the periumbilical region, which corresponds to the T8-T10 dermatome. The visceral peritoneum is often inflamed in the early hours of acute appendicitis, causing the patient to experience vague periumbilical pain, which is referred to the T8-T10 dermatome. Inflammation progresses to the parietal peritoneum, and the pain becomes sharp, severe, and localized in the right lower quadrant. Question 7. What is the pointing sign in acute appendicitis? Pointing sign is when the patient points to the umbilicus, then the right lower quadrant, as they describe the migratory pain that is characteristic of acute appendicitis. Question 8. What is the hamburger sign in acute appendicitis? When talking about the hamburger sign, a patient with true acute appendicitis will decline their favorite food, such as a hamburger, when offered. This is useful in children with vague abdominal pain. Most patients with appendicitis will have anorexia. Onto the physical examination. On examination, she has a temperature of 38.5 degrees Celsius, absent bowel sounds, and marked tenderness to palpation at 1/3 the distance from the anterior superior iliac spine to the umbilicus. While palpating the left lower quadrant, she reports pain in the right lower quadrant. Active flexion and internal rotation of her right hip reproduces the pain. The skin on the right lower quadrant is hypersensitive to touch. Gentle percussion over the right lower quadrant elicits rebound tenderness. There are no hernias, no abnormalities were detected on pelvic and digital rectal examination. Question 9. Where is McBurney's point? McBurney's point is a point located 1/3 of the way from the right anterior superior iliac spine to the umbilicus. It is the superficial landmark for the base of the appendix. Question 10. Where is Land's point? Land's point is a point located on a line between the anterior superior iliac spines, 1/3 of the distance from the right anterior iliac spine. It's a superficial landmark for the position of the appendix. Question 11. What is peritonitis? Peritonitis is inflammation of the peritoneum, which leads to an intense inflammatory response and profound loss of intravascular fluid in the peritoneal space. It can be due to infection and/or sterile chemical irritation such as bleeding. Peritonitis can be complicated by bleeding and sepsis, which may also result from the inciting event. Question 12. What are the physical exam findings in peritonitis? Physical exam findings in peritonitis include excruciating abdominal pain and tenderness, rebound tenderness and jaw tenderness, board-like involuntary rigidity, shallow respiratory movements due to pain produced by diaphragmatic breathing, retching or vomiting, emphasis hypocratica, which is produced by dehydration, pain, and anxiety. Abdominal distension may be present due to ileus. Peritonitis progresses in stages. There's a first stage of prostration or primary shock, then a stage of reaction where there is masked peritonitis, and the stage of frank peritonitis, which has the facies hypocratica. Question 13. What is rebound tenderness? Rebound tenderness is abdominal pain worsened after withdrawal of the palpating hand. It is also known as Bloomberg's sign. It is a sign of peritonitis. The inflamed peritoneum is painful when disturbed, especially when the two inflamed peritoneal surfaces slide over one another. The site of pain is well localized since the parietal peritoneum has somatic sensory afferents. Rebound tenderness can also be elicited by gentle percussion or pinching and releasing. The pain can occur at the site of pressure or remote from it. Question 14. What is jaw tenderness? Jaw tenderness is tenderness produced by the heel drop test. It is also known as Merkel sign. The patient stands on the floor with straightened knees, rises on their toes, then drops to the heels. It is superior to rebound tenderness for localizing peritoneal irritation in the pelvis and in patients with a rigid abdomen. Abdominal pain on walking or running is equivalent to a Merkel sign. Question 15. What physical exam signs are specific for localized peritonitis in the right lower quadrant, which may suggest appendicitis? These signs include McBurney's sign, which refers to maximal tenderness to palpation at McBurney's point, Bloomberg's sign in the right lower quadrant, which refers to rebound tenderness in the right lower quadrant, Rovsing's sign, which is right lower quadrant pain elicited on deep palpation of the left lower quadrant, Iliopsoas sign, which is right lower quadrant pain on passive extension of the right hip or active flexion of the right hip, Cope's obturator sign, which is right lower quadrant pain on internal rotation of the hip, Lance point tenderness, which is tenderness in the right third and left two-third of a line connecting both anterior superior iliac spines, pain in the pouch of Douglas, which is elicited on a digital rectal examination, Dumphy sign, which is right lower quadrant pain elicited by voluntary cough, Merkel sign, which is jaw tenderness, and Baldwin sign, which is tenderness in the right lower quadrant when the patient actively flexes the right hip joint against resistance with the knee extended. Question 16. What physical exam signs specific for localized peritonitis in the right lower quadrant have been elicited in this patient? Signs specific for localized peritonitis in the right lower quadrant that have been elicited in this patient include McBurney's point tenderness, Bloomberg's sign, Rovsing's sign, Iliopsoas sign, and obturator sign. Question 18. Which clinical signs can be used to identify a retrocecal appendix? A retrocecal appendix can be identified by tenderness on palpation of the petit triangle, which is just inferior to the lumbar triangle on the back, and Iliopsoas sign positive. Tenderness may not be elicited on palpating the right lower quadrant because the cecum may prevent the applied pressure from reaching the appendix. A retrocecal appendix may also cause flank pain. Question 19. What are the boundaries of the petit triangle? The petit triangle is bounded anteriorly by the external abdominal oblique, posteriorly by the latissimus dorsi, inferiorly by the iliac crest, which forms the base of the triangle, and the floor is formed by the internal abdominal oblique. Question 20. Which clinical sign can be used to identify a pelvic appendix? A pelvic appendix can be identified by a positive obturator sign, tenderness in the pouch of Douglas, diarrhea since the inflamed appendix is in contact with the rectum, and suprapubic tenderness and tenesmus. A pelvic appendix is more common in children. Inflammation of the bladder may cause increased frequency of urination. Tenderness may not be elicited on palpating the right lower quadrant. Question 21. What could be the cause of absent bowel sounds in this patient? Absent bowel sounds could be caused by paralytic ileus, secondary to inflamed bowel. On to the investigations. A complete blood count reveals leukocytosis of 13,500 per microliter with 15% burns. Urinalysis demonstrates 1 plus white blood cells without bacteria. The pregnancy test is negative. Question 22. What are the critical laboratory investigations and values for the diagnosis of acute appendicitis? Critical investigations and their values include a complete blood count, which shows leukocytosis with a left shift or increase in burned cells, C-reactive peptide, which is elevated, and a pregnancy test can be done for women of childbearing age to rule out ectopic pregnancy. The pregnancy test may be unremarkable, but remember that pregnant women can get appendicitis too. Urinalysis can be performed to rule out cystitis. Question 23. What does the presence of white blood cells in urine without bacteria signify? The presence of white blood cells in urine without bacteria signifies pyuria. It is due to ureteral or bladder irritation by the inflamed appendix. Bacteriuria, which refers to bacteria in urine, should not be present in a catheterized urine specimen. Question 24. What is Alvarado's score? Alvarado's score is a 10-point scoring system using clinical and laboratory criteria to estimate the likelihood of appendicitis. Appendicitis is majorly a clinical diagnosis. Alvarado's score uses 3 symptoms, 3 physical exam findings, and 2 laboratory parameters. These parameters include migration of pain to the right lower quadrant, anorexia, nausea, and/or vomiting. Then for the physical exam findings, there's tenderness in the right lower quadrant, rebound pain, and an elevated temperature of more than 37.3 degrees Celsius. The laboratory parameters include leukocytosis of more than 10,000 per millimeter cubed and a shift to the left of more than 75%. Each score is given 1 point, apart from tenderness in the right lower quadrant and leukocytosis, which are given 2 points. With a score of 1 to 4, the diagnosis of appendicitis is unlikely. A score of 5 to 6, the diagnosis is possible, and an abdominal ultrasound or contrast-enhanced CT scan are indicated to rule in appendicitis. With a score of 7 to 8, there is a probable diagnosis of acute appendicitis, and a score of 9 to 10 means that there is a very probable diagnosis of acute appendicitis. Question 25. What is this patient's diagnosis? This patient has acute appendicitis. Using Alvarado's score, he has a high likelihood of acute appendicitis. Question 26. What is periappendicitis? Periappendicitis is any pathology that causes peritonitis, leading to inflammation of the tissue surrounding the appendix. This can be due to a perforated peptic ulcer or pelvic inflammatory disease. It has signs and symptoms that are suggestive of appendicitis. It can be considered if there is pus in the pelvis, yet the appendix appears non-perforated and non-inflamed. In this case, the abdomen is explored for the source of peritonitis. Question 27. What is pseudoappendicitis? Pseudoappendicitis is a disease that presents exactly like appendicitis but is due to another cause. Yersinia enterocolitis is the classical cause. It presents with right lower quadrant pain, fever, vomiting, bloody diarrhea, and sick contacts. It is self-limiting but can lead to fetal sepsis, especially in immunosuppressed individuals. It is treated with doxycycline. Question 28. What are the imaging tests of choice for acute appendicitis? The imaging tests of choice for acute appendicitis include a right lower quadrant ultrasound and abdominal CT with contrast. A right lower quadrant ultrasound is the best initial imaging test. A CT scan can be performed if the diagnosis is questionable based on history, physical exam, and laboratory findings. Question 29. Is imaging needed for a classic case of acute appendicitis in an adult male? No further imaging is required in the classic case of acute appendicitis in an adult male. The diagnosis can be made clinically. Question 30. When is a right lower quadrant ultrasound indicated for women and children? A right lower quadrant ultrasound can be done when the diagnosis is uncertain. This is the best initial imaging test for women and children. Question 31. What are the right lower quadrant ultrasound findings in acute appendicitis? Ultrasound findings in acute appendicitis include a distended appendix, which measures more than 6 millimeters, an uncompressible aperistaltic distended tubular structure, target sign, where the appendiceal lumen and edematous muscularity are hypoechoic, while the inflamed mucosa is hyperechoic, and a fecalith, which may appear as focal hyperechogenicity with posterior acoustic shadowing. A perforated appendix may be compressible. Question 32. When is an abdominal CT scan ordered for acute appendicitis? An abdominal CT scan can be ordered when the diagnosis is still unclear. It is ordered for adult men and non-pregnant women. CT may not easily visualize the appendix in children since they have less periappendiceal fat. It is very accurate and can be ordered with contrast. Question 33. What are the abdominal CT scan findings in acute appendicitis? CT scan findings include a distended appendix more than 6 millimeters, an edematous appendix with periappendiceal fat stranding, fecalith, which appears as a focal hyperdensity within the lumen, and a halo or target sign. Fat stranding is seen in inflammation. It is increased attenuation of fat in an ill-defined linear, reticular, or reticulonodular pattern. Question 34. Is X-ray useful in diagnosing appendicitis? X-ray is generally not helpful, though a fecalith can be spotted in the right lower quadrant occasionally. Question 35. How can ovarian torsion be ruled out in a patient who presents with right lower quadrant pain, fever, and leukocytosis? Ovarian torsion can be ruled out using a transvaginal ultrasound or CT scan. An ovarian torsion is a surgical emergency. Delays result in necrosis of the ovary, which can only be salvaged 10% of the time. Question 36. How can you differentiate pelvic inflammatory disease from appendicitis? Abdominal pain in pelvic inflammatory disease may be bilateral from onset and is associated with purulent vaginal discharge, and the smear will show bacteria. Pelvic inflammatory disease also has cervical motion tenderness and adnexal tenderness. Nausea and vomiting is also less common in pelvic inflammatory disease. The patient may have risk factors for pelvic inflammatory disease too, which include unprotected intercourse, a history of STD or pelvic inflammatory disease, and multiple sexual partners. CT scan or transvaginal ultrasound can be used to differentiate if unequivocal. Question 37. What is the challenge in diagnosing acute appendicitis in children less than 5 years? It is difficult to diagnose appendicitis in children since they cannot give a history and have frequent episodes of gastrointestinal upset. The appendix is prone to perforate since their omentum is underdeveloped and less capable of containing the rupture. Diffuse peritonitis can also develop rapidly. Remember that children with appendicitis have complete aversion to food and vomit a lot. Question 38. What is the challenge in diagnosing acute appendicitis in elderly patients? The challenge is that abdominal pain presents later in the course and usually has an atypical presentation. The appendix is also more prone to perforate or become gangrenous. They also have a higher rate of morbidity and mortality with a perforated appendix. Question 39. What is the concern if an elderly patient presents with abdominal pain and anemia? This may be due to bowel perforation caused by colon cancer or even carcinoma of the cecum. This can mimic appendicitis in the elderly. Microcytic anemia should prompt for workup of colon cancer. Question 40. What is the challenge in diagnosing acute appendicitis in pregnant women? The challenge is that diagnosis may be delayed as early non-specific symptoms such as nausea and vomiting are attributed to the pregnancy. Appendicitis is the most common cause of extrauterine abdominal pain in pregnancy. Fetal loss occurs in 3 to 5% of cases, increasing to 20% if there is perforation. Pain can also occur in the right upper quadrant as the uterus displaces the cecum and appendix superiorly. Question 41. What is the concern if a patient presents with appendicitis but more than 5-day history of right lower quadrant pain? The concern may be that the appendix is most likely perforated. This can progress into diffuse peritonitis, or the omentum can wall off the perforation to create a localized abscess. Confirm with a CT scan and treat conservatively with intravenous antibiotics. A large abscess, which measures more than 4 centimeters, can be drained percutaneously or surgically. Question 42. What is the definitive treatment of appendicitis? The definitive treatment of appendicitis is appendectomy. It can be performed laparoscopically or open. Incision for open appendectomy include the Gridiron, Lanz, and Rutherford Morrison incision, which is an extended Gridiron. It can be done under spinal or general anesthesia. Question 43. Is appendicitis a true surgical emergency? Appendicitis is treated urgently, but it is not necessarily a true surgical emergency. Surgery may be done urgently within 24 hours to prevent perforation and diffuse peritonitis. An emergent appendectomy is usually done within 8 hours. The risk of perforation is low in the first 36 hours, with a 5% risk of perforation in each subsequent 12-hour period. Question 44. What is the surgical wound classification of appendectomy? An appendectomy is a clean contaminated procedure. It has less than 10% infective rate, and antibiotic prophylaxis may be required. Question 45. What is the role of perioperative antibiotics in acute non-perforated appendicitis? Perioperative antibiotics reduce the risk of postoperative wound infection. It is given to patients with both acute perforated and non-perforated appendicitis. For acute non-perforated appendicitis, intravenous broad-spectrum antibiotics are started 1 hour pre-op and should not exceed 24 hours post-op. For perforated and gangrenous appendicitis, intravenous antibiotics can be given until fever and leukocytosis resolve, which is usually a period of 3 to 5 days. Question 46. How can the base of the appendix be located during surgery? The cecum is mobilized and the tenia coli are traced to their confluence. The base of the appendix is located where the tenia coli meet. Question 47. What is a negative appendectomy? A negative appendectomy refers to a normal appendix that is found during appendectomy. It occurs in 10% of the elderly, infants, and young women. The appendix is removed anyway, and other causes that mimic appendicitis are searched for. If the cause is Crohn's disease, regional enteritis, the appendix is not removed since there is a high risk of forming an enterocutaneous cecal fistula. Question 48. What is the non-operative regimen for appendicitis? The Oshner-Sheren regimen is a non-operative treatment regimen used for the management of an appendix mass, which can be an abscess or a phlegmon. It involves putting the patient nil per mouth, an esogastric tube for decompression, antipyretics and analgesia, intravenous fluid, intravenous antibiotics, and monitoring vitals and the size of the mass. It is performed for acute appendicitis with an abscess or a phlegmon. Abscesses may resolve on their own without antibiotics. Percutaneous or surgical drainage can be performed for large abscesses as mentioned before. Interval appendectomy may be performed 6 to 12 weeks after symptoms resolved. Non-operative management and percutaneous drainage has lower morbidity and mortality compared to immediate appendectomy, but a longer hospital stay. It also has low failure rates, and even if it fails, surgery can be done. The regimen is discontinued if the pulse rate increases, abdominal pain becomes diffuse, or the mass increases in size. Question 49. What is interval appendectomy? Interval appendectomy is an appendectomy that is done 6 to 12 weeks after the resolution of acute appendicitis with a mass. Its main aim is to prevent recurrent appendicitis. At interval appendectomy, often the residual appendix is scarred and involuted. Question 50. Can an acute non-perforated appendicitis be managed non-operatively? Possibly. Surgery or appendectomy remains the gold standard. Antibiotics alone will not prevent the progression to gangrene and perforation, especially when there is a fecalith. However, studies show that 90% of patients with CT-confirmed appendicitis who are managed non-operatively have successful outcomes. Approximately 25% of these patients will require surgery within 1 year of recurrent appendicitis. Non-operative treatment can be considered in patients with high operative risk or in relatively well patients with limited signs. Question 51. What is a closed loop obstruction? A closed loop obstruction is mechanical obstruction of the bowel at 2 points along its length such that there is no outlet for bowel contents and pressure. Pressure builds up and the loop of bowel continues to distend until venous pressure exceeds arterial flow. Blood supply is compromised and ischemia and infarction follow. Question 52. How does closed loop obstruction contribute to the pathogenesis of acute appendicitis? The appendix is a blind loop. Its distal end is closed. Obstruction of the proximal lumen creates a closed loop obstruction. Mucus is secreted and accumulates within the closed loop, causing pressure to build up in the appendix. The appendix distends and intraluminal pressure exceeds venous pressure, leading to venous congestion. Pressure continues to increase until arterial inflow is compromised. The area with the poorest blood supply becomes ischemic and gangrenous. This allows bacteria to translocate into the mucosa and submucosa. The wall becomes weakened and perforates, usually at the antimesenteric border just beyond the point of obstruction where tension is high. Please note that the increased intraluminal pressure alone is not directly responsible for perforation. Question 53. What are the causes of obstruction in acute appendicitis? The causes of obstruction in acute appendicitis include aficholith, lymphoid hyperplasia, which occurs in children, inspissated barium or an impacted barolith after radiological studies, a tumor, such as adenocarcinoma of the carcinoid of the appendix, ingested seeds, and parasites. Ficholith is the most common cause. Lymphoid hyperplasia is also more common in children. Question 54. What are other examples of closed-loop obstruction? Other examples of a closed-loop obstruction include obstructing colon cancer with a functioning ileocecal valve, diverticulitis, an incarcerated hernia, volvulus, acute cholecystitis, and a Richter's hernia. In Richter's hernia, only part of the circumference of the bowel wall is trapped in the sac. Question 55. What are the complications of acute appendicitis? Complications include a perforated appendix, a gangrenous appendicitis, appendiceal abscess, appendiceal phlegmon, and pyelophlebitis. Question 56. What are the postoperative complications of appendectomy? Postoperative complications of appendectomy include bleeding from the appendicular artery stump, surgical site infection, a dynamic ileus, fecal fistula, incisional hernia, adhesions and intestinal obstruction, which are more of a late complication. This, among other general surgical complications such as pneumonia and venous thromboembolism. Bleeding can occur from the appendicular artery stump. Surgical site infection can occur from a break in sterile technique or spillage. It can be organ space, deep, or superficial. A fecal fistula can be caused by leakage from the appendicular stump, inflammation of the cecum, or appendectomy in Crohn's disease. That's it for today. If this was helpful, you can find illustrations, questions, and more on this topic at hyperexcision.com. See you next time.